Hello and welcome. My name is Lisa Paladino, and this is an overview and introduction of A Parent's Guide to TOTs, Tethered Oral Tissues. In this presentation, you will learn what TOTs are, the symptoms that can occur in parents and infants and in breastfeeding that may indicate a TOT. I will tell you a little bit about myself and my motivation to educate about this subject in breastfeeding infants, and I will introduce you to some of the controversies surrounding the issue of tongue tie. This presentation is the first section of the full program. My hope is that you will find this section valuable in itself, even if you don't decide to purchase the program. Of course, since my heart and soul went into creating this for you, my hope is that you will go on to watch and learn all there is to know about TOTs. During the program, you'll hear me refer to TOTs, to tethered oral tissues, to lip tie, to tongue tie, and to buccal tie. We'll go a little bit more into the definitions of those, but for now, let's just say that the terms are interchangeable. So what brings you here? Perhaps your baby is born and breastfeeding isn't going exactly as expected. You may be feeling overwhelmed, confused, and you may be in pain. Either you were told that the baby is tied, or you're suspecting that from your own research. You may have never even heard of tongue tie. You don't know where to turn or who to believe. You are confused about what you're being told. You're seeking expert advice, and of course, you only want the best for your baby. So who am I and why this issue? I'm a registered nurse, a certified nurse midwife, and an IBCLC, which is an internationally board certified lactation consultant. I have been helping new families to breastfeed for over 30 years. Tethered oral tissues treatment has become my focus for the past 5 years. I am in private practice in Staten Island, New York. I've built a team, developed treatment plans, and implemented these plans that have guided hundreds of families to overcome their breastfeeding challenges. I am also the administrator of various social media breastfeeding groups. I'm a founding member of the group, the professional group about tongue tie called ICAP. I have lectured for other professionals regarding the role of the lactation consultant in treatment plans for TOTs. Most importantly, I am a wife, a mother, and a lifetime learner. The picture of the group in this slide is one of our annual World Breastfeeding Week celebrations, one of the social media groups that I run. And underneath there is myself in my office examining a baby. The middle picture is one of the babies that I helped midwife. And that's a picture of me in the corner. My motivation for creating this course is to share my approach with more families than I can reach in my office, because I hear of so many breastfeeding failures without professional guidance. It's my mission to guide as many families as I can to reach their own personal breastfeeding goals, whatever they may be. So what is a tongue tie? The frenum, also known as a frenulum, is a band of tissue that attaches the tongue to the bottom of the mouth and the lip to the gum line and the cheek to the inside of the gums sometimes too. Tethered oral tissues are abnormally formed or tight attachments, also called frenum, in the mouth that prevent functional movement. There are 3 types that seem to affect breastfeeding. The lip, which can be maxillary or mandibular, depending on the position. The tongue, which is called linguinal. And the cheek, which can be pronounced as buccal or buccal. Ankyloglossia is another term for breastfeeding. And tethered oral tissues, or TOTs, is an acronym that was developed in order to encompass all of the various frenum that can cause oral restrictions. In order to breastfeed, an infant must be able to open her mouth wide, then lift her tongue while keeping her mouth open. The TOTs prevent this and therefore can prevent effective and comfortable breastfeeding. Most importantly, this is not a diagnosis or assessment that can be made just by looking at pictures like these. TOTs is a definition of function rather than form. In other words, it is about what the tongue can do rather than what it looks like. I borrowed this slide from Dr. Larry Kotlow, who is one of the leaders in this field. This might represent what you are feeling. I mean, no offense to any category of healthcare professionals. There are providers of all categories who do and do not understand about TOTs. Unfortunately, families are often caught in this tug of war between providers. The good news is that the information and education can transform this power struggle. As a parent, it may be hard to be confident to follow what you know is the right thing for your child. My hope is that education about this subject will help you, even if your healthcare provider hasn't been educated about TOTs or about breastfeeding. Now let's talk about symptoms of TOTs in parents. Painful breastfeeding, nipple and or breast pain, with or without visible trauma. This can vary from a bit of redness to cracked to bleeding to infected nipples. After nursing, the nipple can appear flattened. It can have a crease or a lipstick shape, and it might not be the same on both sides. This misshape may last for a few seconds or it may last for hours. Cracked or bleeding nipples, frequent clogged ducts, engorgement, nipple blebs or mastitis, oversupply or low milk supply. TOTs can have these effects on the breast due to a poor latch or inefficient drainage of the breast. A parent can also have these symptoms without the infant having TOTs. Incorrect positioning, prior breast surgery or abscess, patterns of breastfeeding, early supplementing, birth trauma, other infant conditions, and various situations can also cause these breastfeeding challenges, which is why an IBCLC is the best professional to evaluate the symptoms by evaluating the feeding. What's interesting about milk supply is that some infants seem to cause their parents to produce more milk in order for them not to have to work so hard at the breast. This makes sense from an evolutionary standpoint. But as far as I know, there isn't any evidence to support this. And it's possible that the same inflammatory process that led to the tethered oral tissue is also what's affecting mom's supply. Low milk supply seems to make more sense. If the gape of the mouth isn't wide open and the infant can't get a deep enough attachment, there is less milk removal from the breast and less breast stimulation, leading to lowered supply. I'll share with you a patient story. This parent came to me during the first week of life. She had a cracked, bleeding, and infected nipple, and when she did a Google search, it seemed that her baby might have a lip tie. When I examined her baby, yes, there looked like there was a frenum that was thick under her lip and a prominent frenum under the tongue. But the mobility and the function of the lips and tongue seemed to be good. Then baby latched, and I observed that the mom was holding the baby too far away for her to get a deep latch. I helped her adjust the baby in the way she was holding her and got her to latch comfortably. We then healed her nipples by some treatments, and within 3 days she was nursing comfortably and efficiently. What mom would have done if she had just relied on a social media diagnosis or sending a picture somewhere is she might have brought the baby for the procedure, might have caused unnecessary pain, and it wouldn't have healed her nipples or decreased her pain just by getting the procedure. There are also symptoms of TOTs in the feeding. Difficulty latching, noisy nursing, sometimes a clicking noise, biting or chomping on the nipple, slipping on and off the breast. Any infant who cannot latch should be evaluated by an IBCLC for TOTs. Breastfeeding is the first normal biologic function after breathing that the infant has to do in order to survive. I see so many parents who are told that the infant can't latch because of the parent's anatomy. For example, I recently had a mom in my office who was told by the nurses in the hospital that her nipples were too flat for breastfeeding. This makes me incredibly sad. The first days of breastfeeding can be so overwhelming without thinking that the reason your baby isn't eating is because of something that you can't change, like the size or shape of your own nipples. The truth is, in my experience, in most circumstances, if there is not an oral restriction like a tethered oral tissue, the infant can make a teat out of the nipple and draw it out and deep into their mouth, no matter what the shape or size of the nipple or what it looks like without the baby feeding. Very often, the problem lies with the infant's anatomy, not the parents. Noisy nursing can be caused by either the infant taking in air or trying desperately to stay onto the nipple, which can be very hard to do when you can't lift your tongue and open your mouth at the same time. Both the biting and the slipping on and off can be symptoms that are caused by the same desire of the infant to stay on and to feed, which are both difficult for him or her without full functional movement of the tongue. Other symptoms can be that the baby falls asleep while nursing, nurses for a long time, and then wakes up as soon as he or she is put down, or has lots of sucks and not too many swallows. About once a week, I have a family in my office that describes that the infant is nursing fine. He nurses all day long. Mom is exhausted. The infant never seems full. And many first-time parents think that this is normal, that infants should feed all of the time. In reality, infants typically feed for a bit, fall asleep, and give an hour or two in between the next time they need to be fed. What happens when an infant has a tot is that it may only be getting sips at a time. It's like snacking all day long instead of having meals. It's slow going. Think about only getting appetizers and never being able to sit and be served a full meal. Now picture eating the appetizers while walking on a treadmill. Unfortunately, for some kids, this is what it's like. They have to make such an effort to get the milk out, it actually burns calories for them to eat. I often see infants that appear to be eating all day long and are actually losing weight. Lots of sucks are going on during these feeds, but not too many swallows. And IBCLC is educated to show you how to know the difference between sucking and eating at the breast. She can evaluate for swallows as well as sucks and help you to distinguish when there is snacking versus a meal going on. In the infant, the symptoms may be slow or excessive weight gain. If there is oversupply, there may be very fast weight gain. If there is low milk supply, There may be slow weight gain, even in those infants that seem to be nursing all day long. There may be colic or gas, reflux, spitting up, explosive poops, blisters on lips, or a white coating on the back of the tongue. A little bit about the colic, gas, reflux, and explosive poops. When the infant is at the breast, if the seal isn't as it should be and the motion of the tongue and mouth aren't ideal, the infant can get lots of air with feeding. The air can lead to colic, gas, spitting up, or explosive bowel movements. I like to explain the digestive system as a tube. What goes in the tube must go out of the tube. The tube starts in the mouth and ends in the butt. If extra air goes in, it can come back out as spit up, go lower and get stuck, causing pain, which could turn into crying and colic, or it can make it to the lower digestive system, which causes gas pockets that push the poop out explosively and can also be unpleasantly smelling. The symptom of blisters on the lips are often seen in an infant that is trying to hold on with the lips instead of making a nice seal with the mouth and tongue movements and the positioning that produce the suction that extracts milk. I also see many parents who think their infant has thrush and it's actually a tongue tie. A white coating on the back of the tongue may be because the normal tongue movement will allow the tongue to clean itself in the typical situation. The tongue that isn't held down can brush against the top gums and the top of the mouth to clean itself. Take a moment to move your tongue around your own mouth. Can you scrape your tongue on your upper teeth? If you had a tongue tie, you wouldn't be able to do that. So the infant who has the restriction isn't able to clean his tongue naturally and may get that white coating on the back of the tongue. Let's talk about controversies and myths now. Because this is something that is not taught in nursing or medical school, or even a part of the curriculum that we study to become lactation consultants, there are only a select group of providers who have educated themselves and are proficient in this area. I've listed some of the myths that you may hear about TOTs, and I'll talk a little bit about each one. Painful breastfeeding is not normal. It shouldn't hurt to nurse your baby. I feel so strongly about this that I actually wrote a book with that same title. There are a few things that can cause breastfeeding to be painful, and most of them can be corrected. I do not believe that anybody should suffer with painful breastfeeding without reaching out for professional guidance. There are those who do not believe in TOTs. In my opinion, this should be heard as I haven't learned anything about tongue tie yet. If the baby can stick his tongue out, then he isn't tied. Actually, breastfeeding and many other functions of the mouth require the tongue to move side to side and up and down. Being able to stick the tongue out is not a test for tongue function. As far as the TOTs improving as the child grows, or hoping that a fall will break the tie, that's a little upsetting to me because I really wouldn't want to hope that my child fell and cut his mouth open. And young children with difficulty feeding or making some sounds are often found to have TOTs. All that matters is that baby is gaining weight. Really? Mom's or baby's comfort doesn't matter? There is so much more to feeding than weight gain. As I've mentioned, TOTs are not just about breastfeeding. There is so much that the tongue does for us. We need our tongue to eat solid food, to drink from a cup, to speak, and to keep our mouths clean. Also, the tongue is an important muscle whose movement and position in the mouth help form the oral airway. Adults with sleep-disordered breathing are now being evaluated for tongue tie, and there is a correlation. As far as the release of TOTs being dangerous or needing general anesthesia, the professionals who are expert in treating TOTs understand that this is a simple procedure in the right hands that can be done under local anesthesia in the office. It takes less than 5 minutes from start to finish. There are very few risks. When someone is trained well in the procedure, the complication rate is next to zero. The providers that I refer to and recommend for the procedure use a laser, and it's a very quick laser procedure. As far as the newborn being too young to have a procedure, I'd just like to say that there's a lot of infants, especially in this country, who have routine circumcision within days of being born. I'm not going to give my opinion on that. It's a controversial issue in itself. But I will say that the procedure to release a tongue tie is much quicker, less painful, less traumatic, and has far fewer complications, especially when performed by an experienced provider. And then the pendulum of the controversies and myths can swing so far or too far in the opposite direction, thinking that releasing tongue tie will solve all breastfeeding problems. And that's not true, because not all breastfeeding problems are caused by TOTs. The goals of the program, Parents' Guide to TOTs, is to understand TOTs symptoms, how they impact infant feeding, understand the implications beyond breastfeeding, understand the role of an IBCLC, and to know how to find a treatment team. This course represents what I have learned and experienced with the families that I treat in my office. After the course, you will understand the importance of timing and readiness for the procedure. Know that TOTs aren't the cause of all breastfeeding issues. Feel informed and educated about TOTs. Be confident in any choice you make for your infant, and feel supported and prepared with a plan of care for release of TOTs if you make that choice. My wish for all parents is that you reach your own feeding goals, whatever they may be, and to find the support and the knowledge and the experienced guidance so that you can make the decisions for yourself. The course includes why the guidance of an IBCLC is necessary for complex breastfeeding concerns such as TOTs, how to select a provider for frenotomy, how to prepare for the procedure, an explanation of the procedure including videos of frenotomy, and frenotomy is the word for the procedure of releasing the frenum, what to expect after frenotomy, and understanding the process of a team of care, including body work. In my opinion, there are situations that are giving the treatment of TOTs a bad name. TARs are being diagnosed on social media, they're being treated by those who don't know how to fully release them, or are ignoring lip and buccal ties. Then there are some babies who are treated without any guidance from a lactation consultant, and there are babies who are having the procedure that shouldn't be. These are set up to be failures, and those who go through this or hear about this think that the procedure either wasn't successful, made no difference, or in the worst cases, made things worse. Without the support of an experienced breastfeeding professional, if there are breastfeeding difficulties that have nothing to do with the tethered oral tissues, the release of those tethered oral tissues will not fix anything. And even when the TOTs are contributing to the breastfeeding problem, without proper and professional lactation care, the procedure alone may not lead to a solution. I'm going to share a personal story. My kids are grown now, and I had no breastfeeding support when they were young. After learning about TOTs as an IBCLC, I realized that 2 of my 3 children have restrictions. No wonder I had trouble breastfeeding. My youngest daughter, who was born with a cleft lip, also has a posterior tongue tie, but no one ever looked under her tongue. This experience adds to my motivation to help other families who struggle. No one should be without knowledgeable guidance. Thank you so much for your time and attention. I hope that this introduction to TOTs has been helpful to you. The purpose of the course and the whole program of Parents' Guide to TOTs is to provide education about TOTs and professional experience guidance through the protocols that I have used to guide hundreds of breastfeeding families to decide if release of TOTs is necessary, and if so, how to prepare to make this as easy as possible for you and your infant, and also how to proceed through the procedure and recovery. I am so grateful to all of the families that have trusted me with their care through this procedure, and I am grateful for all of you for taking the time to listen. Thank you for watching this presentation. I hope that you have found it helpful. It is my mission to help all families reach their own personal feeding goals. The link to order the full program follows this video or can be found at my website at lisapaladino.net. If you think that there are other families who would benefit from the information in this presentation, feel free to share this. Thanks so much.